multidisciplinary team, medical supplies and self-care management of diabetes in Zimbabwe. When you're looking at the prevalence of non-communicable diseases worldwide, it's increasing demand on the healthcare system. The focus is on empowering the non-communicable disease patients to be able to monitor and to take care of themselves. So hence the need of self-care management of chronic diseases. This is based on the Lalonde Health Report, which is one of the iconic health reports that were done in 1978, which targeted on highlighting the 4 components of health. And from this Lalonde Health Report, we had the focus on health promotion, wanting to empower the patients to promote health so that we can have the patients be able, or not the patients rather, but the society be able to take charge of the health. In the Lalonde Health Report, it has 4 categories, which are the human, biology, environment, lifestyle, and healthcare organization. So my focus of this study is looking at the self-care management of diabetes and what are the components contribute to self-care management of diabetes. And in this particular report, in this particular study, I focused on availability on healthcare system, particularly availability of a multidisciplinary team and medical supplies and utilities. So the biggest challenge of healthcare providers today is addressing the continued needs and demands of individuals with chronic diseases like diabetes. Patients who are diabetic, they need regular follow-ups. They need to go to the hospital regularly for them to evade the long-term complications that come with diabetes. Like we know, when you have chronic diseases, they come with a cluster of other diseases. So regular checkup is important. And then, so the purpose of self-care management strategies is to help patients make management choices that allow them to achieve success in reaching self-goals. But they cannot do this in isolation of the healthcare system. So the global picture we can see on the diabetes, we see that every year over 4 million people die from diabetes, and over 10s of millions suffer from the disabling and life-threatening complications that come with diabetes, because there are so many complications that come if people do not regularly check their glucose. And so diabetes has become a global societal catastrophe when you are linking all these complications that come with diabetes. Looking at the prevalence, projections of the prevalence of diabetes, by 2030, the expectation is over 208 million people will be having diabetes. And looking at the prevalence and undiagnosed cases in the world, when you're looking at South and Central America, we have a prevalence of about 27.4%, North America 27.1%, Europe 33.1%, Southeast Asia 52.8%, Western Pacific 53.6%, Middle East and North America 48.3%, and Sub-Saharan Africa, where Zimbabwe is, it is about 62.5%. So you find that the prevalence of diabetes is high in Sub-Saharan Africa, and which is actually a paradox, because this is a lifestyle disease, and that's why we are talking about the double, even the triple burden of disease, that they are still battling with communicable diseases, but still the burden of non-communicable diseases is increasing. And looking at mortality from the same, these statistics are from the International Diabetes Federation 2014. So the mortality of diabetes, you still find that it is high in Sub-Saharan Africa, with a mortality rate of 76%. This was from the records of IDF 2014. And coming to the picture of Zimbabwe, Zimbabwe, it has a prevalence of, the diabetes prevalence is at 10% for people that are older than 25. Of course, when you're looking at the US preventive task force, the onset age for diabetes is 40, but in Zimbabwe, we have the onset age being as low as 25, and having 10% of people having diabetes. And of course, they say because of the resource limitations that are in Zimbabwe, this statistic, it came from the IDF based on a survey which was done in 2005. And I'm sure, we do not have a current prevalence statistic on Zimbabwe. This was from 2005. This is due to resource limitations and the lack of comprehensive population surveys in Zimbabwe. And so the diabetes ranking in Zimbabwe is fifth among the NCDs in public hospitals. And due to late diagnosis or limitations in treatment access, most of the people, they die within 5 years of diagnosis. So when looking at the core components of diabetes care and self-management, because the focus is we want to empower the patient to be able to monitor themselves, to be able to make better choices with regards to their lifestyle so that they manage their diabetes. So there are core components for diabetes care and self-care management. The first one is treatment, because you still want them to regularly check their glucose levels. You still want to check, to monitor if they're developing any complications. So treatment for diabetes patients is critical. So because you want, there is clinical monitoring to achieve glycemic and metabolic control through the provision of essential medicines, provisions of essential technologies and services, and provisions of, so this is the plan from the International Diabetes Federation. This is the plan that they have for 2011 to 2012 on the core components of self-care management of diabetes. So what you find that if you have a weak health system, you will not be able to address these core components on self-care management of diabetes. So the healthcare system becomes a major bottleneck for the diabetic patient to be able to manage their diabetes. So the healthcare environment affects individuals' ability to adhere to self-care management treatment. So the patient may be knowledgeable about what they're supposed to do, but the bottleneck can still come from the healthcare system. So for this research, I use the patient's needs model. The patient needs model, it puts the patient first, the person who has the chronic disease, and comes the healthcare system, where they are going to have their visit the hospital. They need to find the multidisciplinary team to be attended by different people, different specialists, the community, and then the society. But so this is the patient's needs model. And so my focus was only on the patient and the healthcare system for them to be able to achieve self-care management. So the purpose of this study, the study aimed to investigate the extent of the healthcare factors in terms of availability of medical supplies and utilities, availability of a multidisciplinary team. This multidisciplinary team is having different experts attending to the diabetic patients, not only the physician. You need the nutritionist, you need the person to get their eyes checked regularly, they need to have their kidney function tested regularly, they need the feet specialist. So these are important components for the healthcare to provide to the diabetic patients. And also looking at the self-care management of diabetes mellitus among the patients, and which of these two healthcare factors predict self-care management. Of these factors, which one influences self-care management of diabetes the most? So the significance of the study, number one, it's primarily on healthcare facilities so that they can increase the quality of their services. Also, the way the health personnel work with diabetic patients, and establishment of the multidisciplinary team.
Data collection was done in all the 10 provinces in Zimbabwe through AATA. A diabetes self-care management program was conducted for the respondents. All the participants had their blood pressure and random blood sugar levels checked. The questionnaire was explained to all the participants, and most of the respondents filled in the questionnaire by themselves. Only a few respondents requested for assistance to fill in the questionnaire. A research assistant was used, who is a diabetes nurse. She has a master's in public health and postgraduate diploma in diabetes education from Australia. Majority of the respondents were females at 73.5%, and most of the respondents were in the age category of 41 to 60 years old. All the participants were above 35 and were diabetic patients for more than a year.
So this explains the data collection process. I did data collection in all the 10 provinces of Zimbabwe with 340 respondents. I'm sure you saw the statistics on the demographics of the respondents. So for the method, of course, this is a quantitative method. I use descriptive correlation study, and also I did regression analysis. So for the results, using the descriptive analysis, the medical supplies and utilities in hospitals and clinics that they visited, these the respondents, were rarely available with a mean of 2.233. And also looking at the multidisciplinary team, it was also rarely available to attend to the diabetic patients. Some of the questions that were on the questionnaire, I've highlighted them. On the issue of availability of medical supplies and utilities, I asked them if when they visit the hospital for checkups, do they get the monitor my blood sugar regularly? That is the facility that they have. Do they have their eyes examined every year? Because this is a recommendation from the International Diabetes Federation and also the US Prevention Task Force and the International Diabetes Federation. They put the specifics that are supposed to be done when someone attends a healthcare facility. They have to get their HB1AC tested twice a year, testing of cholesterol, testing of the urine every year for kidney problems. So you can see that from these recommended tests that they are supposed to have from the healthcare facilities, the majority of them, they were like rarely availed to the patients, or even in some cases, never. The one on checking of cholesterol yearly, which is a recommendation. So from these results, and also when I asked these are some of the questions that I asked on the availability of a multidisciplinary team, looking at if the healthcare professionals, are they there to set the goals with the patient, to set self-care management goals with the patient? When they develop complications, are they referred to specialists? Is diet counseling part of the services that they receive when they go for checkup? Dental services, I mean, there were so many other questions that were there, looking at what type of specialists are they referred to? And on this availability of multidisciplinary team, on almost all the questions, they were never referred to as specialists in this area. It would be either the nurse who just explains everything to the diabetic patient. And so the extent of self-care management, these questions were, I was asking the patient how much they care for themselves according to these questions. Do they follow a healthful eating plan every day, their savings of food that they eat, looking at the exercise, how they take care of their feet, how they check their weight. And on this self-care management, actually it was average on the part of the patients. They had average self-care management. And the second research question looked on the prediction of which of the factors predict self-care management between availability of multidisciplinary team and the presence of medical utilities and supplies. So using the regression analysis and ANOVA, both factors came out in the regression model, with medical supplies and utilities with a standardized coefficient of 0.198, and the R-square change, as you can see, was 0.350. For the multidisciplinary team, the standardized coefficient is 0.179. Of course, you can see the t-value and the significance, which is at 0.000, and the R-square change is 0.038. And based on this, we can say the predictors for self-care management, number one is the more available the medical supplies and utilities are, the better self-care management. Because looking at the R-square change, it provided 35%. So furthermore, availability of medical supplies contributes 35% to self-care management. So if you want to empower the patient to be able to take care of their diabetes, to be able to monitor, you need availability of medical supplies in the hospital, because it contributes 35% to their self-care management. And also availability of a multidisciplinary team increases self-care management in the respondents. From the R-square, which we had, it is a contribution of 3.8% of self-care management. So also looking in the literature, this was confirmed by Asayad, Mueller, and Nirenta in 2014. They noted that patients who received suboptimal care from the hospital due to unavailability of services and tests reagents at hospital often had a low self-care management. And also a qualitative study which was done in 2013 on perceived barriers and facilitators in diabetes care, and they found that presence of a multidisciplinary team facilitates diabetes self-care management. So this leads to the conclusion that both medical supplies and utilities and multidisciplinary team were rarely available. The respondents had average self-care management of diabetes, and these factors on the healthcare, they both predict self-care management, with the greatest contribution coming from availability of medical supplies and utilities, with a contribution of 35% to self-care management, and the multidisciplinary team 3.8%. So what does this mean? So this leads to the recommendations that I have, at least for the healthcare providers, looking at the fact that availability of medical supplies and utilities contributes 35% to self-care management. Healthcare providers must develop strategies to enhance the quality of care and services they give to the diabetic patients. This is shown through the availing the recommended test and services to the patient, and also availing the different expertise that the diabetic patients require, because we want to avoid development of complications, so they need to be attended to by different people. So diabetes management should integrate different health professionals from different disciplines to attend to diabetic patients. And in addition, the healthcare professionals should to guide their patient to better self-care management, so that they can move from the average self-care management that they have to something which is better. And also, when you're looking at the person with diabetes, people with type 2 diabetes should aim towards improving self-care management. The Ministry of Health in Zimbabwe should strengthen the support for self-care management of chronic diseases, because we cannot only give the people knowledge on how to have self-care management without strengthening the support that they find from the hospital facilities. And I'm sure some of you might have seen in the news, currently in Zimbabwe, there's a strike by medical doctors. So this is like a call that the Ministry of Health or the government should support the services that they give to the patients, and adequate resources should be available for patient education and quality healthcare services. And with this, I thank you.
Questions open now. Any question, any contribution? Diabetes self-care management for those who are suffering with diabetes, how they can better take care of themselves and the factors that can influence that. Dr. Bonya.
Dr. Mbiriri, thank you so very much for the presentation. Something that maybe I missed, maybe I was listening to myself to something else. In the way you did your study, did you take some interest in the self-care management of diabetic patients? Those who use that little small instrument like the glucometer just to check themselves how they are doing and recording the values, how they are doing. What was it like? Maybe I did not listen carefully, but I think that's one of the things that that helps maybe when people are diabetic and they want to check themselves on a regular basis where they're up or low or something like that. So how was it like when you talked to some, or maybe when you interviewed some, the availability of that kind of instrument?
Okay, so when I did not include that question. Just on the extent of self-care management, I also asked those questions. But on this sample that I put of the questions, I did not include. But I looked. In fact, I had one question which looked at, I test my blood sugar. This was like they should test their blood sugar regularly, and I also had questions on what do they do when they see that their blood sugar level is out of range. So I checked. So based the verbal interpretation of the extent of self-care management, it shows that they have average. Because some of them, sometimes they did, like you can see from the scaled responses, let's see that I test my blood sugar. So we can say the mean is 3.87 and the scaled response was often. Say they oftenly check. Of course, upon asking them, because after this we did a seminar, like I mentioned in the data collection method, most of them did not have their personal glucometers. They had to, mostly they go to the pharmacy where they get checked for $1 to get their blood glucose monitored.
Thank you very much for the presentation. I have a kind of comment that perhaps looks beyond the presentation. I appreciate that this was part of the thesis that you did at that point. Mm-hmm. But now in the context of the discussion we are having about the church and the people and you as a public health practitioner, I wonder if you have thought about it to say, where does the church fit in terms of the multidisciplinary teams that we are talking about? Because I'm understanding that within that you are having more than just one cadre. Yeah. And then I'm also wondering the responsibilities of the individual patient. Because it is one thing to say, yes, the facilities don't have what I need. And I can see they're checking their weight and the like. And I wonder if maybe beyond this study, there is somewhere where we see the patient taking control within the society, within the limitations that they have.
Mm-hmm. Okay, thank you so much. So on the role of the church, actually out of this study, I developed a model where I put the different stakeholders. And I've specifically mentioned the church, the role of the church. So I may share the model with you that I developed. Of course, this is just a small part of the dissertation, but I had the output of this was to develop a model. So one of the stakeholders in that model is the church. So I will share with you. And of course, we looked at the extent of self-care management, asking them the questions of what the patients are doing, because the ultimate goal is to empower this person to be able to take care of themselves. This is a lifestyle diseases primarily, so we want to have the patient be able to take care of themselves, not to rely on the outside, yes, on the system, but at the same time, we do not want to disregard the system. It was like, so what percentage does the system contribute to your self-care management? But you as an individual, you have the responsibility.
Thank you so much. Maybe one more question. This is my wife, and I wouldn't want to have too many questions. Any more? Okay, I think we can put our hands together for Dr. Mbiriri. Thank you so much. We are ready for the next presentation.
Okay, our next and last presentation of this morning